Today's topic is management of diabetic foot in primary care. Before we start, let me go through a few housekeeping rules to ensure the smooth running of the session. Please keep your mics muted and your video switched off. Please post all your queries down in the chat box and we will address them at the end. All participants will be issued with a participation certificate under two requirements. Number one, you have to be present for 75% of the lecture. Number two, you have to fill out the feedback form. The link for the feedback form will appear in the chat box sometime during the lecture. Please rename yourself with the name that should appear in the certificate. Tonight, our guest speaker is Dr. Thushan Gunaratne, Consultant Vascular and Transplant Surgeon at NHSL and Senior Lecturer in Surgery, Faculty of Medicine, University of Colombo. Dr. Gunaratne graduated from the Faculty of Medicine, University of Colombo with a second-class upper honours in 2009, with distinctions in anatomy, surgery, obs and gynae, with the Rockwood Gold Medal for surgery. He obtained his postgraduate qualification in surgery, MD Surgery, in January of 2016, ranking first in the order of merit, receiving both Virasa Pillai Gabriel Memorial Gold Medal for General Surgery and the Milroy Paul Gold Medal for Clinical Surgery. He obtained his MRCS in July of 2016. He received his gold certification in February of 2020 after completion of his foreign training services at the Leeds General Infirmary in the UK. He furthered his training by obtaining a Master's in Vascular and Endovascular Surgery from the University of Edinburgh in 2020 and was awarded the James Hogarth Priggle Medal for top-ranking CHM student for the year 2019-2020. He also completed the doctorate in medicine in research on his thesis, The Role of Insulin in Amelioration of Skeletal Muscle Reperfusion Injury. Dr. Gunaratne, over to you, sir.
Thank you very much for a very kind introduction. Wasn't expecting the entire thing to be read out. Thank you very much. I hope I'm audible and I can be heard.
Yes, sir, you're clear.
Lovely, fine, thank you. Okay, let me share my screen. Right. Okay, lovely. So first of all, may I kindly thank the Sri Lanka College of Specialty Family Physicians for the very kind invitation, especially to Dr. Prabhatna and Ekara for personally inviting me for this excellent program of yours. And it's an honor to be a part of this program. If at all at some point I'm not clear or my audio breaks down, please do let me know. And I'll adjust myself appropriately. I thought I'll talk about the management of the diabetic foot, its relevance to the management in the primary care level as well. However, as was requested, I will continue to talk more about at least some parts about the specialty level management as well, so that we both are aware as to what happens for such a patient. And between the various components of diabetic foot care, I'll probably concentrate more on the ischemic component, but you got to be aware that there are other aspects of diabetic feet that are relevant in terms of disease. But feel free to ask the question at the end, and I will appropriately answer if time permits. Lovely. Okay, so let's move on. So hope I'll be able to, at the end of the session, you'll be able to get some understanding of what the disease burden is, bit of the epidemiology, how you would probably look into manage and assess a patient when you do find somebody coming to your practice with either a critical limb ischemia or a diabetic foot ulcer, and to know some basic principles of management of such a patient. To begin with, I think it's important to understand that atherosclerosis, peripheral vascular disease, is a huge problem. It's a global problem. And if you look at how things are and how things are expected to turn out, we do expect that with the growing burden of disease, that is going to be a significant prevalence in terms of disease proportion, as worse as coronary heart disease. It's also a problem of aging, and if you look at the various studies that have been around, it's very, very clear that the prevalence of peripheral vascular disease, including critical limb ischemia, is just going to grow and grow as the patients grow older. And as Sri Lanka, as much as the countries around, it's a geriatric and aging population. So far, we do expect that in 2012, about 12.5% of our patients are over 60 years, and it's expected in a few years' time, it will be around 25% of the population. So it's going to be a problem that we're going to live with for the rest of our lives as our practicing clinicians. So what happens is that for whatever reason, that there is going to be excess cholesterol and fat that deposits within the wall, and the wall therefore gets thinned, the wall gets blocked, and the lumen gets narrowed. And as that happens, the blood supply to the limbs are going to get compromised. It's also a marker that it happens to the rest of the body, not simply in regards to the feet or the legs. It's really important because if you look at mortality that is associated with peripheral vascular disease, they die actually from strokes or cardiac events. And the combination of these two actually probably causes a 6 times greater risk of mortality from dying from cerebral vascular or cardiovascular events for somebody who has peripheral vascular disease when compared to someone who doesn't have peripheral vascular disease. If you look at what risk factors are there, and I think it's very common, it's much familiar to you, there are very, very strong risk factors for peripheral vascular disease. Amongst them, smoking and diabetes tends to be a hugely important component. They're probably the biggest contributors to peripheral vascular disease. So diabetes is going to be a problem, and right now, diabetes is a worldwide pandemic. The South Asian area is going to be a huge burden. It's a growing pandemic and epidemic as well as for our own region. If you look at Sri Lanka, 1 in 11 people has diabetes. That's according to recent studies. And that's probably looking at about 1 million patients right now in Sri Lanka with diabetes. So what does that mean to us? That means that at least 1 in 3 of these who are over 50 are likely to have peripheral vascular disease. So of the 1.3 million, we're expecting quite a significant proportion going to have peripheral vascular disease as well. Diabetic foot has a lot of components, and that's what I want to mention at the beginning. I'll probably concentrate on some of these things, but you've got to remember that some of them are actually not related to vascular disease. That can be diabetic foot infection, and the patients can present you with abscesses and all those things. There are people who have ulcers, and that can be ischemic or non-ischemic. Some of these patients, of course, end up with a vascular problem, and you find these presentations of gangrene. There's tissue death because the blood supply is compromised. There's an entity called charcoal foot, where there is no ischemia, but the foot has significant deformity, and that leads to neuropathic ulcers happening. The end result is that patients are going to lose tissue. That can be in terms of minor amputations for some patients, and some people will end up with a major lower limb amputation. So this spectrum of disease needs to be made aware in terms of a surgical problem of diabetic feet. So if you do add diabetes and peripheral vascular disease together, what is known is that these patients have a 15 times higher risk of having a major lower limb amputation. And this is a significant amount. If you look at Sri Lanka, and this is based off some studies we have found, if you look at when we've assessed and analyzed our patients who undergo amputation, 85% of them are diabetic. There's a significant contribution of diabetes to this problem. If you look at what happens to them long term, and this is also important, we often think of important cancers like breast cancer causing mortality, but the reality is 5-year mortality for breast cancer is about 12%. If you add a patient, non-ischemic, with simply a charcoal foot, then that patient has a 5-year mortality of 25%. If you add an ulcer on top of this, a patient having an ulcer, no ischemia, then the mortality is high as 30% over 5 years' time. And that's almost equivalent to all cancer mortality of 5 years. Now, if for whatever reason some of these patients are going to end up with a minor amputation, the mortality is 45%, 50% almost. That is even higher than the all cancer mortality. Things are continuing to get worse if you add patients who have peripheral vascular disease and critical limb ischemia, those who have vascular problem and diabetes together, their mortality is even higher. If they have a major low limb amputation, you're looking at about 60% mortality. And the only cancer that has even higher mortality than this diabetic population with peripheral vascular disease is probably lung cancer. So it is really important that as clinicians and as people who are probably more involved in patients with primary care level as well, it's really important that we understand that if we prevent an ulceration in diabetic patients, there's a huge mortality benefit. If a patient has an ulcer, it's very, very important we try to heal it. And if you have to lose tissue, try and have a minor amputation. And it's absolutely crucial we try and prevent a major lower limb amputation in these patients. So from the beginning onwards, it's really important we try and prevent all these disease from happening. From medical point of view, and diabetic clinicians will tell how important it is to talk about the right diabetic foot advice, the footwear, the foot care. I'm going to stick away from all those things for the moment, but it's absolutely essential that these things are taken into your practice as well. Right, and just to share some data before we get to the main topic itself. Patients who have a major low limb amputation, the 30-day mortality now was 6%. 6% actually don't even make it past a month. And 5 years, the survival was 35%, the mortality of 65%. That's probably equal or probably worse than the global guidelines. And this is National Hospital. What is also was clear is that those people who lose their leg, they hardly ever find prosthesis. If they do use the prosthesis, it's purely for a cosmetic reason. So they never get back to a normal day-to-day lifestyle. If you look at patients who are undergoing a revascularization, those who had the opportunity to have a bypass or endovascular intervention, the mortality is a lot significantly less compared to those who have a major amputation. So 30-day mortality is about 5%. And 5 years, survival is about 50%. And that's relatively common across the global guidelines. So just to remind again, it's important that we're able to diagnose these patients with diabetes, to look after their feet so that they don't get ulcer. And if they do get ulcer, it's really important we try and heal them. And it's really important we try and avoid a major low limb amputation in these patients a lot. Okay, so I thought I'll discuss today's topic in terms of a clinical case, make it more relevant, and perhaps something that most of you might have encountered. And feel free to ask me a question or send a chat message in case you want to interrupt me for a question or to clarify something. So, it's Mr. Sunil, 65-year-old gentleman, is diabetic, known to be diabetic, comes with a toe discoloration. The hallux of the right side foot is discolored. There's a small discharge that comes from the angle of the nail. Initially, as most of us would, given oral antibiotics for a potential nail bed infection. Looks so far very standard. But even after 5 days, the patient comes back. The discoloration is continuing. Now we complain of pain around the toe. With the antibiotics, the discharge is less, but still there's a problem happening. He goes to the local hospital, and they felt that there's diabetic foot infection involved in the toe, and the toe amputation was done. Subsequently, the wounds doesn't seem to really be healthy, so therefore they felt that the wound edges were unhealthy. They wanted to do further debridements. So in the casualty theater, they done further debridement and surgical cleanup, because they worried the infection seems to be spreading into the other toes. And at some point was offered an amputation. So the initial toe lesion that looked like what it was, when he comes to the hospital to see us, it's actually progressed quite a bit into quite a considerable size of a wound. He's already lost one toe. The second toe also looks blue and discolored. The wound looks very unhealthy. Unfortunately, very common. It's a very common scenario. So I think the first thing I wanted to ask and wanted you all to think was, where have things gone wrong? If you were the person who were managing this patient at the beginning, how would you have managed this situation? Would it have been any different? Was there an error in the judgment from the onset? Were we wrong to do various things? Um, would you perhaps have thought about blood supply? Would you not have removed the nail or the nail bed infection? Would you be worried about sugar control? Would you like to assess a neuropathy? And maybe management would be trying to think of things like offloading. Was the infection not controlled properly? Was the antibodies not right, not good enough? Or were there other general situations that needs to be sorted out? Um, so a lot of things are there, and I probably would agree that even all those things might be right. So it's really important that when you see a patient with a diabetic uh, issue involved in the feet, especially, how am I going to assess such a patient? And I think there's two aspects to this, as assessing of the patient and assessing of the foot as well, and the lesion involved. So when it comes to the patient, uh, I don't want to be going to too much specific, but it's a general assessment of the general hydration, the nutrition, looking for fits of inflammation, infection, uh, systemic response to disease. Are there risk factors? The medication, are things under control? The comorbidities and complications of these comorbidities. And unless a patient assessment is done and the entire patient is managed, it doesn't really help to look at the foot alone and manage the wound alone. So don't forget to look at the entire patient. But in terms of the foot, what am I looking for? What are you going to look for to see if this is a problem that is going to be something that needs special attention? I think if you can look at these important things, and these important things are there to suggest that this is a high risk foot. And the important things here are looking for neuropathy, looking for deformity, for infection, and vascularity. And we call these the VIPs of diabetic foot assessment. V for vascular, I for infection, P for pressure, and that would be part of neuropathy and deformity. So these components are the essential criteria you would look for when you want to see a patient with diabetes and looking at their feet. And if you look at this traffic light system of trying to categorize them into various risks of having a problem, I'll start from the lowest rung of the green color as a low risk. And these patients actually have no risk factors. So no loss of sensation, or no loss of protective sensation, no signs of peripheral vascular disease or other risk factors. And as these risk factors build up, the presence of deformity, presence of loss of protective sensation, presence of peripheral vascular disease, presence of chronic kidney disease, then the risks become higher and higher. And the appropriate action you take for these patients are different based on the various risk factors. If you look at the very top of the active component, and these are patients who have active ulceration with or without ischemia, there's gangrene, there's unexpected redness, erythema, pain or without pain, then basically what is required is to rapidly refer these patients to a patient that can be assessed by a vascular surgeon or a vascular team or a multidisciplinary team. So just think about these components that you need to assess. And I go back to these four components are essential to look for when you see a patient. And we'll try and see how we do this and how we can pitfalls of doing this. But these four things are the very, very important aspects of identifying a high risk foot. Right. So first thing was neuropathy, and I think you're very familiar with this. A part of diabetic foot screening, the monofilament test is something that is used. There are various methods of confirming the presence of neuropathy. In practice, it could be 3 points or 4 points, and finding whether the sensation is sensed by these patients if you use a monofilament. I think it's an essential tool to have, essential piece of equipment to have if you're having diabetic foot practice. Vibration is not something that is often done, but is as equivalent to a monofilament test. And if there is neuropathy, that needs to be considered. A second most important thing is deformity. It's a very, very obvious things to be mindful of. And you see, if you look at the feet, you'll notice deformity. Our feet have a particular shape, arches, the way the toes are. And if these are lost, that was signifying that the pressures of the feet are not appropriately spread out as we walk. There can be people with charcoal feet, with hammer toes, claw toes, and any form of deformity with diabetic people. And the presence of neuropathy is going to predispose them to forming pre-ulcerated tissues. So these things like calluses are all part of a future ulcer that can happen. So looking for deformity in any form is very important. I'll talk more about tooth components because it's going to spend more with a little time frame, and because perhaps these are the two areas where things go wrong and difficulties are there to try and assess and to manage. And of these two, one is infection and one is ischemia. So let's just see how and why we can see how infection is there or not. To begin with, any ulcer that a patient has is contaminated. There's always going to be bugs. And actually, lower levels of bacteria are not a problem. It's probably okay to have lower levels of bacteria. You never have sterile wounds. It's the high levels that are detrimental. If you look at the spectrum of how this infection and presence of bacteria are there in a wound, contamination is always going to be there. But at a certain point of time, as the build-up of organisms take place, there's a critical point where the invading bacteria tend to get into the vessels and invade into tissue. That is when infection is going to happen. So we want to make sure we identify patients in the infected state or those who have a likelihood of critical colonization. Those who are colonized and contaminated are not people we're worried about. So if you swab any wound, it is very likely to grow an organism. So it's not a problem. There are people who have high risk for infection and glycemic control if it's poor, those who have neuropathy, ischemia, poor fitting shoes, bad footwear, bad foot care, they're going to be high risk for diabetic foot infection. So when do we suspect then? We like to have all these classic signs of inflammation. If you look at, if you remember the old acute inflammatory features, erythema, the warmth, pain, tenderness, these are stuff we knew about. The redness, the hotness, the inflammation, the swelling. But the problem in diabetic feet is that these are not always present because of their immune response or the lack of immune response. So a high degree of suspicion is really required in some people to suspect infection. Now, these pictures, of course, are very, very clear. You can see the swelling, you can see the discoloration, the skin is blistering. You know there's a problem going on. You might even see discharge coming through, right? But sometimes it is not the case. And if you look at the various criteria, I don't want to spend too much of time on it, but there are certain guidelines that would tell you as to whether there is local wound infection or whether there's deep infection. And local infection would just require topical therapy. But if there's deep infection, then the patient will require more systemic therapy and sometimes debridement. The IDSA guidelines are the ones that are considered to be more appropriate. I'll just share the pictures here, but I don't want to spend too much time. But various criteria are looked at to diagnose the presence of infection. So if this slide is visible to just have a look at it, there are some important things we look at. And if there are at least 2 of the 5 items on that list, that includes local swelling, erythema, tenderness, warmth, and discharge, then we would consider these patients to have a mild infection. And as the depth of tissue invasion increases, the severity increases. If it enters the bloodstream, these people are having severe infection. Another thing that is important is to consider whether the bones are involved. And that's a classic test we would do in the clinical practice and the GP practice and the primary care level, is to probe the bone to see if you can feel the grittiness of a bone. And if you can feel a gritty bone at the base of the wound as you probe, there's a high chance that this patient will be probably having some form of osteomyelitis. Various investigations can be done, blood tests, imaging, x-rays, but I think however much we have all these facilities, End of the day, it's about a clinical acumen and suspicion. So if you look at the guidelines, and they suggest, even in the global guidelines, diagnosis of soft tissue infection is a clinical diagnosis. And it's really important that you be aware that the signs of foot infection might be less obvious. So you need to press along the tendon sheets, press the wound, and look for potential focuses and collections of discharges as we examine. Feel for warmth, look for areas of induration. In patients who you do have equivocal findings, these investigations are useful. If you suspect osteomyelitis, that's really important because the management slightly differs in the presence of osteomyelitis. All clinically infected tissues, if you can, do try and collect appropriate specimen for culture, and that is preferably a clean tissue sample. There are local guidelines, and I'll share some guidelines with you as to what antibiotics you would use. The duration of antibiotics would depend on the degree of infection. I don't want to spend too much time on it, but if you look at the guidelines given by the College of Microbiology, they'll tell you as to what antibiotics you would use for mild infection, severe infection, for diabetic foot ulceration. And if you think there's osteomyelitis, how do you manage those? If you think there's severe diabetic foot infection with systemic sepsis, what are the first line antibiotics that you would use? So useful to be aware of these things if you have a diabetic foot practice. So what we would consider as the ideal sample would be a clean tissue sample from the wound bed, and that should be collected carefully, aseptically. So rather than blindly giving antibiotics for a long time, if you have a patient with a diabetic foot ulcer and you are suspecting that infection, it's useful to try and be aware as to how you might collect such a sample. So sometimes the infection is very covert, not very clear. The base of that wound has infection, there's infected tissue. You might see blisters, so there's infection going on, and there is spreading infection along the tendon sheets, and there's probably some form of necrotizing fasciitis, very dangerous with diabetic foot disease. Sometimes there's infection and ischemia. You can see dead and gangrenous tissue, and this needs to be cleaned up and debrided properly. Make sure that the entire source of infection has been removed. So this is not uncommon. So going back to Sunil, was it wrong therefore to debride the nail infection? That was what was done at a primary level at the local hospital. Now I'm going to share a few pictures here, and then we'll see whether it makes any sense. Two scenarios, and you can tell me what it looks like. So this patient has very clear diabetic foot infection, marked areas of pus, purulence, edema, and at local hospital or at a GP practice, this wound was nicely cleaned, and you can see good healthy tissue. This patient again has a ulcer, and on the heel of the wound, notice that there is an area of induration pointing out in a different spot to where the wound is. And actually, this is a communication of the same ulcer infection, and the wound has been cleaned up nicely surgically. This is another similar scenarios, presence of infection. It looks necrotic, looks bad, looks ischemic, but the wound has been cleaned. It actually doesn't look so ischemic now. It looks a lot well perfused. This is without any form of revascularization. Again, on the patient, you can see necrotic areas, infection is there. You can see it seems to be tracking down the previously amputated foot-toe down to the mid-plantar spaces, and this wound has been cleaned. Another picture looks very bad to begin with. The wound has been debrided, and the wound looks local. Now look at this scenario. This is again debridements that have been done for infection. Toe has been removed, heel has been sorted out, cleaned. The wound doesn't look the same. Another patient. It looks nothing like the old pictures I told you about. Another picture. Debridement looks hardly like it's a healthy wound. So what's the difference between these two scenarios? Why is it that some patients with a debridement looks okay, another patient with a debridement does not look okay? And the reality is, and the most important factor here, is the presence of perfusion. So debridement in the presence of perfusion versus debridement in the absence of perfusion. So in infection control, it's really important we try and identify infection early. It's very important to do that. But even if you do diagnose infection, how you manage that infection depends on assessment of the perfusion as well. Because these two go hand in hand in diabetic foot infections, and unless you identify it, you could fall in trouble. So my second or last of the four components is to talk about how one could assess the adequacy of perfusion. Right, I'm going back to the old picture again of how the cholesterol builds up in a blood vessel, and you can see how the lumen is narrowed. And I'm going to try and link these to cardiac disease because it's a lot more familiar to most of you. And we know patients who have a blocked heart vessel, they have angina, where as they walk for a particular distance, there is going to be anaerobic metabolism because the blood supply is not enough at that point to meet the demands of the muscles of the myocardium. And therefore, patient builds up lactic acid, there's going to be pain. And there's angina. As the patient rests, the pain disappears and he can walk again. So that typical angina that you see in coronary disease is something like intermittent claudication of the leg. So that is basically angina for the low limb vessels. Now, sometimes that plaque builds up, but we know that as the plaque builds up, there's going to be plaque disruption where the fibrous cap can break off as it builds up. And if that happens, there's going to be thrombus formation. This can lead to complete obstruction or a variable obstruction. Now, in a cardiac situation, this could be something like unstable angina or a transmural myocardial death or a myocardial infarction. And this entity for coronary disease is called acute coronary syndrome. Now, this unstable angina, where there is tissue, not tissue death yet, but a significant amount of obstruction, that is sort of like a rest pain in our patients. And when there is complete obstruction and tissue death because of various lack of collaterals, then that tissue loss is going to be the end of the spectrum for us as well. And acute coronary syndrome is what we call as critical limb ischemia. So just remember that we talk about peripheral vascular disease and the presence of ischemia or perfusion. These people can be asymptomatic. Those who are symptomatic could be having intermittent claudication, that's Fontaine 2, and some of them will be in critical limb ischemia, that is either the presence of rest pain or tissue loss. Let's just try and go through these things so you can try and identify these patients early in your clinical practice. So assessment of perfusion is primarily reliant on history and examination. So in clinical history, try and see if there's a history of claudication in these patients. Did Sunil have a past history of claudication? Does Sunil have rest pain? So claudication, the classic claudication is a cramping as a patient walks. Like the chest pain, they get a calf pain. They will have to stop after a particular distance, and when they do walk back, the pain recurs again. Rest pain is different. A very classic example of such patients, they are absolutely unable to sleep at all with their legs up. They're either sleeping on the couch or they're sleeping on the bed with their legs hanging down. And it's a classic pain that happens at night. And even with simple analgesia or strong analgesia, they do not settle. They require opioids. And for some patients, even opioids are not enough. That's classic rest pain. So if patient has something like this, then there's a clear sign that the perfusion is compromised. So Sunil, unfortunately, has no history of claudication, no rest pain. So somebody might think, look, if these are not there, then probably peripheral vascular disease is unlikely. And we can take a small few seconds to think as to, what so then, if it's not there, then is it not having peripheral vascular disease? But when it comes to diabetic patients, especially, there is quite a significant proportion that don't have claudication, nor do they have rest pain, and that's called masked peripheral vascular disease. Most of these people are old. They might not be walking enough to get claudication. There's restricted mobility. Neuropathy is almost always there in all these patients. And the rest pain is basically a nerve pain, and you do not get the rest pain in patients who have established neuropathy. The disease is involved in the infragenicular arteries, that's below the popliteal arteries. They actually won't have calf claudication also. So various reasons for peripheral vascular disease in diabetic patients, they may not have a history of claudication, nor may they have a rest pain. So examination revolves around trying to find more important things because the history might not be reliable. We talk about thin skin, reduced hair growth, brittle nails, muscle wasting. These are common to most of the elderly population and not very reliable. Pulses are very important to be aware of and need to be assessed in your patients, especially when they have diabetic foot problem. I've listed out the important ones: the femoral artery, the popliteal artery, the posterior and the dorsalis pedis. Things like coldness are not very obvious in our patient population. So going back to pulses, we would like to feel the pulses, and if the pulses aren't there, to say, look, there are no pulses, therefore this patient has peripheral vascular disease. But unfortunately, absence of pulses cannot confirm peripheral vascular for many reasons. There are many false negatives when it comes to pulses. Sometimes there's leg swelling, especially with rest pain in older people. There's calcified vessels. You can't feel a pulse. Technique is important to know exactly where to feel the pulse, and sometimes you might not feel pulse because of poor technique as well. So, not very reliable to be 100% sure as to whether peripheral vascular is there or not. So, while we want to have the classic features of history and the classic examination things on assessment for perfusion, it's important that none of these might be possible for some of our patients. So that poses a problem. In reality, in our patient, the history is, even though there is no history of claudication or rest pain, the patient has absent pulses in the popliteal artery as well as in the foot. He has a femoral pulse and nothing else. And in the presence of tissue loss, absent pulses, chances are this patient actually had peripheral vascular disease with diabetic foot infection. So his neuropathic assessment was positive. There was no deformity, there's tissue loss, there's infection, and absent pulses. And for any other person, this would be a diagnosis of critical limb ischemia. So unfortunately, up to this point, it was very, very subjective, but there are objective measures and assessments that can be done as well. This part of the discussion might not be relevant to all of y'all. Certain things from this point onwards require special tools that you might not have, but be mindful that these are there in tertiary centers, but it's not essential to have in a primary care setting. If somebody has a clinical practice with diabetic foot disease, I think having a Doppler is very important, because important test we do for some of our patients is an ankle brachial pressure index. It's a technique of doing that. Basically, what we're doing is checking the ratio between the ankle pressure of the patient as well as the pressure of the brachial or the arm, and you look at the ratio. And if the ratio is less than 0.9, that suggests a diagnosis of peripheral vascular disease. In our patient, the patient's ABPA was measured after we saw the patient, and the ratio is actually 1.4 at the posterior tibial artery and 1.2 in the dorsalis pedis artery. And going back to this chart again, it's actually the normal value is about 1. This is perhaps abnormally high. And this is a problem with diabetic foot disease. The reason is that in diabetic foot disease, ABPI is unfortunately not reliable because the tibial vessels cannot be compressed. So that poses even more problems. The objective measure of having a Doppler and doing an ABPI might not be reliable because these vessels in diabetic people cannot be compressed. It is reliable for non-diabetic disease, but not for diabetic disease. So what is recommended is something called a toe pressure. It's not available in most centers in Sri Lanka, but useful to be aware of that is what is required, and be mindful that you will probably get a falsely high ankle pressure index in these people, and don't assume that means the blood supply is good. We don't have TCO2 in Sri Lanka, but there are other tests that can be done, um, and guidelines will tell us in terms of what these cutoff values are to diagnose critical limb ischemia objectively. But coming back to what our real situation is in our practice, um, we would like to have assessment of the history and examination and judge purely on that. And it's a clinical diagnosis. If you are not feeling the pulse, there's ulceration, the wound doesn't look good, don't think twice, refer to a vascular unit and let them assess and find out. Common question: how soon should the patient be referred to a vascular surgeon? And the answer to that is as soon as possible. With every single day that the patient is kept in the primary care level, there's increasing tissue death, tissue loss. A lot of questions are asked when in that patient, when there is necrotic tissue, should we debride them and send the patient? A simple answer: if the patient is septic, yes. But what we don't want is to patients to undergo multiple debridements, um, uh, and then send the patient once they diagnose a blood supply issue, because at that point the patient might not be even be able to have a potential to save the foot. Another question that is often asked: shall we arrange a duplex scan to send the patient and to confirm that there's disease of the perivascular disease? And the answer is absolute no. Duplex scan cannot diagnose or confirm perivascular disease. We do not do it. It's not recommended. Getting duplex scan is a very laborious task. Cannot easily get something done soon, and the time lost for that is too much. So we are very happy if somebody refers a patient early with the suspicion of vascularity issues, and we can assess and refer and send the patient back to you if the patient has intact vascular supply. Okay, so our patient come back to Mr. Sunil. There's absent foot pulses, API wasn't reliable, we don't have toe pressure. Now, what do we do? What can we do? So then there's the issue of more technical aspects of vascular disease and diabetic foot disease. How do we decide when it comes to critical ischemia and how to manage it? So we have a few options, and it's important that all these options are appropriate for some people. We would like to revascularize. That would mean to restore blood supply. That can be the open bypass, can be endovascular, can be hybrid. Sometimes the option for the patient is to remove the tissue, that's to amputate. It could be minor amputation or a major amputation. For some people, we do nothing. This do nothing can be palliation. It could sometimes be watchful waiting and try and see if a small lesion can be healed or not. So when we look at a patient, when we see a patient like Sunil, there are important things we look at after diagnosing critical limb ischemia to decide what are we going to do. And there are three spheres. We look at the patient to understand what the patient's risk factors are. We look at the wound and the limb, and look at the anatomy. And we look at all these three things in combination when you want to decide as to what we would do. When it comes to the patient, basically what we want to know is, can this patient withstand an intervention? Is the patient a high-risk patient? Is this patient expected to live for a long time? Based on active heart failure, ejection fraction of 15%, global hypokinesia, can't even lie down, orthopnea. There's no point in trying to embark on a significantly morbid procedure. When it comes to limb, then something that's going to be difficult to assess. What we want to know is, what is the risk of losing this leg if we don't do something? Should we take the risk and accept the morbidities involved and embark on a revascularization procedure? So how do we do that? How do we say that this is the risk of limb loss? What is the risk of amputation? If we don't do anything and just manage with wound care, is this patient going to lose the leg or not? That's a very important question to answer. And that is how the Wi-Fi score comes into place. If anybody has seen this Wi-Fi score, I think very important to know these components. It's probably not important to know the subcomponents, but to be aware that when we look at a patient, we look at the wound, look at the ischemia, look at the presence of infection, and this is useful to determine as to what risk this patient has. If you look at Sunil, what's the wound score? And wound score for him is going to be wound 2. It's a deep ulcer and gangrene to the toes. Ischemia, we don't have toe pressures, but there are various ways of calculating this using ABPI also, and that's probably going to be a Wi-Fi ischemia score of at least 2 or even 3. Coming back to the picture, infection. There is no spreading infection in terms of sepsis, but there's definitely local infection. And I would think this moderate infection with more than 2 centimeter cellulitis. So in general, for our patient, we probably think of a Wi-Fi score of around 6. Now, what does this score mean? Right, wound 2, ischemia 2, and foot infection 2. And this Wi-Fi table, if you look at it, would put this patient into the column of red area. There's a high risk of having a lower limb amputation. And the bottom chart is going to tell us the benefit of revascularizing in this patient lot. The top chart is for the risk of amputation. So he has a high risk of a major lower limb amputation within the next year, and he has a high benefit of revascularization. So based on this patient would be a patient that should be considered for doing something. And then therefore we'll decide either the patient will have wound care or we should amputate. But if you are planning to revascularize based on the Wi-Fi score, then we need to know the anatomy. If the patient is high risk for a procedure, they should be either amputated or manage the wound. If the limb situation is so bad that it can't be salvaged, then the patient will have amputation. But if the patient can have a salvageable limb and the patient is fit enough to undergo, then we need to know what the anatomy is to decide what is the best option. So, So then therefore we will do some imaging. And you see the duplex scan actually comes only at this point. We only use the duplex scan to assess the anatomy when we have decided patient has critical limb ischemia and we want to consider revascularizing. There are other methods of assessments of the anatomy, CT scans, MRI scans, and angiograms. I don't want to spend too much of time on this, but these scans have their various pros and cons. Some are operator dependent, and they give various information, the anatomy, the flow rates, all of those things, where the blocks are, where the blocks aren't, and therefore we can plan out as to what we should do. In terms of the different types of locations, we normally talk about 3 areas: the part above the groin, that's even a femoral pulse is not there, and patients who have femoral popliteal disease, where the disease is between the femoral artery and the popliteal artery, and those who have infragenicular disease. And the diabetic people are only the infragenicular components. So the idea is to establish pulsed flow to the area concerned. We want a very strong flow of blood coming to the ulcer and the tissue loss area. Most of our work happens in open environment, and we do bypass surgeries. This is an aorta bifem surgery. This is a distal bypass where the patient's vein has been plumbed on to the GTB arch, the dorsalis pedis arch of the foot. Another such a surgery, and this is using a prosthetic bypass. So various options are there. We can convert a wound like this into a wound that is going to heal, because diagnosis has been made early, patient has been appropriately referred at the right time, the wound is small, patient is fit enough, the Wi-Fi score suggests patient would benefit from revascularizing, his anatomy has been assessed, and the bypass has been done. So the entire spectrum of things have happened in order to save the patient's foot. And even feet that would normally be considered for amputation can be salvaged. So a bypass basically has the best short-term and long-term outcomes. However, it has drawbacks. The mortality early on is quite high because it's a big surgery, wound complications can happen, They have to spend longer in hospitals, and it requires presence of good quality veins to be a successful bypass. And this is technically quite demanding. So, in the vascular has taken into place, is basically this uses various balloons and stents. If you look at the global pattern of how things are, there's a gradual increase of the use of endovascular interventions in terms of when compared to bypass surgery. And the endovascular arm is significantly gaining interest in modern day vascular surgery. Especially most of the patients are comorbid, have heart disease, have MIs, have CABDs done. So they become less and less fit for open intervention. I'll skip these slides, they'll probably be too much, but there's a lot of evidence that is around to suggest as to what should be the first choice for these patients. But in general, if a patient has a life expectancy of more than 2 years, patient has a good quality vein, we would like to think of doing an open bypass surgery. It's been resonated in the recent bestseller trials that just came out, the largest randomized trials, that an open bypass patient is probably a better option for patients with critical limb ischemia. So our patient, Mr. Sunil, has a POP PT bypass planned. It was done under combined spinal epidural. The remaining toes were removed. There's a nice algorithm that one could look at to decide as to how this can be managed. But this was Sunil's journey as he was diagnosed with critical limb ischemia. His risk factors were managed, the wound was cared for, antibiotics and sepsis treatment was done. He was considered for revascularizing, imaging was done, it was considered feasible. He was for a bypass first approach because he had a good quality vein and he was fit enough, successfully done, and with wound care, patient has a healed wound. I thought I would mention a few things because I was requested to talk a little bit more about more complex stuff as well. Basically, angioplasty is about putting a balloon and trying to open up so that the lumen wall can be increased. It basically crushes the plaque to the side walls. This can be a simple balloon, and sometimes we use stents to try and keep the balloon out. It's not something that is often done like in the heart. We don't often like to use stents in peripheral vascular disease apart from the iliac arteries because stents don't do well with the blood vessels below the groin. There's a lot of interest in drug-coated balloons, and this is thought to help in terms of long-term outcomes. There is a lot of information that is happening and interest because in diabetic disease, a lot of calcium happens. I told you that calcification is why you might not feel a pulse. And the balloon can't open up and break calcium. There's a use for atherectomy, where they try and shave off and cut their plaques with calcifications. So basically, just to let us all know, when it comes to diabetic foot infection, I think identifying things early is very, very crucial. Being aware of the high risk features. What are the high risk features that would tell me there's a problem going on? And if you are able to identify them early, the patient can be referred early to a vascular surgeon if there is presence or suspicion of infection. I didn't talk about wound bed preparation. It was not something I want to talk about today in terms of the context of what we're going to talk about. It's a separate lecture itself. But wound bed management is very important as to how you would think about managing a wound. It's really important that the entire patient is assessed and the entire patient is optimized. Infection has to be controlled if it is there, suspect it early, sample it early, if required, drain early. Very important that ischemia is identified and looked at and referred to early. Use the right dressings. Don't forget about footwear. Don't forget about foot care, about offloading. The patient is a person and comes as a whole in terms of family members and a society. And unless the entire family members are also included, this will never ever work. We cannot look at these patients alone in the tertiary center. The patient has to be referred to us, and the patient has to come back to the community and to the community region if they want to survive and to look after the wound. And the real important thing is that it requires a lot of teamwork, and all of us need to be able to work together to sort this out. We want to see less and less of these sort of things happening. Tight bandages on ischemic limbs, not looking after the wound properly. Wounds are destroyed because of poor wound care. Continuous debridements. We don't want to see these sort of patients come into our practice where multiple debridements have been done, the feet mutilated, simply because somebody couldn't identify ischemia. We want to see more patients who come early and where we can help in terms of sorting the blood supply out and healing these wounds. And then these wounds can be healed in whatever format they come if they're sent early and if the patients are diagnosed early. And want to see happy faces at the end of it, and that can only be done if they're sent early, diagnosed early, and looked after back in the community. Final note, I don't think it's anyone's baby. Wounds are going to be a problem in future. There is a huge requirement for wound care, and I think everyone is involved. It's not as to what our professions are or what our category of administration we are, but it's your interest you have that will drive you to look after feet and to look after these patients. So thank you for that, and I hope I've been able to impart some knowledge and some enthusiasm into this problem. It's a big area, but I thought I'll just concentrate on certain aspects that are relevant to family physician because it's very important that you are able to do some important components, and without your help and assistance, this is never going to work. So thank you for that. Happy to ask any questions if they are there, and I'll hand over the control of the mic back to the college. Thank you.
Thank you, Dr. Thushan Gunaratne. If the participants have any questions, we can have a few minutes for that as well. Okay, it seems there are no questions. So on behalf of the College of Sri Lanka College of Specialist Family Physicians, I would like to thank Dr. Thushan Gunaratne for this valuable and informative lecture. And your expertise have greatly enriched our program. And I would also like to thank Dr. Prabhat for arranging this lecture. And dear participants, please fill the feedback form. And there may be a few questions so that you can obtain the certificate, CPD certificate. And in addition to that, I just wanted to let you know that this lecture would be uploaded to the official YouTube channel of our college probably tomorrow. So you all can have a look at it. So if you don't have any questions, we can call it a day. Thank you again, and good night.